get going, and I'll always give everyone a few minutes to join. So welcome everybody. I know that this will take a minute for everybody to join, so you'll hear us be a little bit quiet as we give everyone a few minutes to filter in. A couple of updates as always. Please make sure you tell us who you are and where you're calling from. That'll be really helpful for us to know all the different places that people are tuning in and joining from today. And we'll start in just a second with some introductions and of course some updates. Couple of quick reminders before we hop in, some things that we always cover. First and foremost, this is not intended to be therapy or replace therapy. Instead, this is intended to be an educational series where we really give some feedback, share a little bit of our expertise, professional and personal opinions. But again, we do not want this to replace therapy. So in particular, specific questions, we will answer them broadly, but you really should consult with your individual clinician or therapist. As always, this is not a crisis hotline. If you're feeling unsafe or suicidal, please call 911, visit your local emergency room, or call the suicide hotline. We know many of you will be joining from across the globe, and so if that's the case, please make sure you look into your own emergency services. As always, a couple of updates. Remember, IOCDF does the Lunch and Learn with Liz every 2 weeks. We do Live with Liz every 2 weeks as well, so on subsequent weeks. And then Ethan does his series, Just Ethan, every Thursday night as a way for us to continue to engage and work together with the OCD community. Please make sure you say hi and tell us who you are and who is joining. Couple of updates. They are doing, IOCDF has an anxiety and athlete survey that is up. We ask anybody who is an athlete in the OCD community to please complete this survey, as we're really looking to ramp up education, research, and support specific to athletes with OCD and anxiety. The second is an amazing new initiative, which is a faith-based initiative that IOCDF is working on. Whether you're a member of the OCD community, a faith-based leader, or a clinician, we really value your input in around the ways that anxiety impacts faith-based communities. We're trying to make sure we increase education and support to these communities, as this is often, as many of us know, a first line of resources and treatment that many people seek out services from. Of course, you can join the Peace of Mind and IOCDF virtual community at iocdf.org/peace of mind. This is where you will hear all about and be able to see any upcoming events, surveys, things that we're doing. And this is also where you can go and post questions that you want us to answer at our next live stream, or if there's specific content you want to make sure that we address, this is where it will be addressed. The IOCDF is now accepting applications for the 2021 Research Grant Awards. Please visit iocdf.org/research to learn more. And of course, our annual research symposium is also now accepting applications. So please make sure you check out the same link below for that. Hi, Meryl from Pennsylvania. Good to see you. I know others are here, so please say hi and let us know who you are and where you're joining from. I'm really excited about today's topic. Today, we're going to be covering an educational series focused on medically based treatments for OCD. You guys know that I talk all the time about CBT and ERP, and you've gotten a lot of content around behavioral-based treatments, right? So behavioral interventions, therapeutic-based treatments that are more psychology-based. Today, we're going to talk much more from a medical perspective, and we have no one better than Dr. Wayne Goodman joining us today. Dr. Goodman is actually one of the original founders of the International OCD Foundation, has been in our field for many, many years, and is certainly known as one of the leaders and groundbreaking scientists in the OCD community. Many of you actually use a scale that he developed, the Y-box, and that is something that is not just highly disseminated, but used very effective and validated as a way to measure OCD symptom severity for patients with OCD. Dr. Goodman is an amazing psychiatrist. He's the Irene Elwood Professor and Chair of the Menninger Department of Psychiatry and Behavioral Sciences right here in Houston, Texas, where we're both joining live from at Baylor College of Medicine. He specializes and has spent his career specializing in obsessive compulsive disorder and deep brain stimulation for intractable psychiatric illnesses. He's the principal developer of the Y-box, the Yale-Brown Obsessive Compulsive Scale, which is the gold standard for assessing OCD. He was a co-founder of this foundation, the International OCD Foundation, and has just been a huge advocate for OCD and groups and patients with OCD. Prior to joining Baylor, he held the senior administrative position at Mount Sinai Hospital in New York, NIMH, and the University of Florida. He graduated from Columbia University with a degree in electrical engineering and received his medical degree from Boston University of Medicine and completed his internship, residency, and research fellowship at Yale School of Medicine, where he remained on their faculty for 7 years. He's currently a principal investigator on grants from NIH's Brain Initiative, including one on developing adaptive DBS for OCD. I personally know Dr. Goodman as an amazing mentor, friend, colleague, somebody I've worked very closely with, and someone that I can tell you advocates on behalf of OCD like no other and has made a huge difference in our field. So thank you for joining us.
Well, thank you so much, Liz, for having me.
It's my pleasure, and I am excited. Hi, everyone. Seeing lots of people from the U.S., from Dublin, Nebraska, Delaware, all over. So please continue to let us know where you're calling from. And as always, if you guys have questions, things you want us to address specifically, please put them on the comment box that you see in the right-hand pane, and we will do our best to address them. So today, what are we talking about? We're really shifting from our ERP and CBT conversations. Those are still critical, and you'll hear us use those words, I'm sure, on and off. But we're going to talk a lot about the medical model. And so I would love, Dr. Goodman, for us to just start there, for us to spend a second hearing about kind of the past 30 years, what's happened as far as medical interventions and treatments for OCD. Where did we start, and where are we at now with medication and other options?
Yeah, so that's a great question. So when I started in the field, and it is about 3 decades ago, my focus was mostly on medications. And at that time, there were no medications approved for the treatment of OCD. And I was involved in some of the early studies that first showed that clomipramine or anafranil was effective in OCD, and followed that up with additional studies with the selective serotonin reuptake inhibitors, the SSRIs. Trade names that you're familiar with include Prozac and Zoloft, and escitalopram is also another medication, and Luvox is another one that people are familiar with. Anyway, we demonstrated, and it wasn't obviously not just me, but many investigators in the field over the years demonstrated that the serotonin reuptake inhibitors, whether the selective ones, the SSRIs or clomipramine, were effective in treating OCD, whereas other antidepressants that weren't serotonin reuptake inhibitors weren't. So that led to a hypothesis that made a lot of sense at the time, which was that serotonin must be involved somehow in the cause or contributing factor in the symptoms of OCD. And I spent many years, and so did others, published many papers, most of them negative, trying our best to identify a problem with the serotonin system in the brains of people with OCD. Not looking directly in the brain so much, but looking at peripheral markers of serotonin, doing imaging. And although there's still strong evidence that the serotonin system is important, this is a neurotransmitter in the brain that's important to the treatment of OCD, we haven't found any evidence that, like checking levels of serotonin or is going to help us identify what the cause is or make the diagnosis. Then later on, maybe a little over a decade ago, halfway through my career, start to become interested in looking at OCD from a circuit standpoint. And that was kind of helpful having the electrical engineering background. I was used to looking at electrical circuits. And there were these brain imaging studies that began to show that certain regions of the brain seemed to be more active in patients with OCD compared to people that didn't have OCD. And furthermore, and this is a very interesting finding, is that if you treated people with OCD successfully, whether with behavior therapy, specifically ERP, or with the serotonin reuptake inhibitors, when you repeated those scans, those areas that were overactive weren't active anymore in the brain. So that's led to us trying to define not only a single region, but a number of different regions in the brain that form a circuit that may underlie the symptoms of OCD. And that in turn has given us the opportunity to start looking at neuromodulation. By neuromodulation, I mean the use of medical devices that through either magnetic fields or electromagnetic or electrical fields can modulate different points or nodes of that circuit and lead to an improvement in symptoms.
And so when we think kind of like hierarchy of medical interventions as far as what's first, I think that most people would assume the first line treatment would be standard psychotropic medications. And so can you talk a little bit about kind of that course? So what would be like the first line you would try with a patient with OCD before you try augmenting and then moving to these?
Yeah, so the first would be picking one of the SSRIs. And again, that could be, Prozac or Zoloft or Luvox. And there's no evidence to suggest that one is superior to another, but there are enormous individual differences in patients. So one patient may do very well on Prozac, and another one won't. And so it makes sense to first do a trial of the SSRI that you started with. And it's important not to give up too soon. What we found pretty early on is that it takes a long time for these medications to work. And you have to give it at least 8 to 12 weeks. You don't want to, and there is some evidence that patients with OCD might need higher doses of these medications compared to patients with depression, but I wouldn't start at higher doses. I think it's really important to go up gradually, being really attentive to side effects, make sure people tolerate it, and then gradually go up to perhaps a little bit higher dose. But I wouldn't give up until tried for about 8 to 12 weeks.
Okay.
And then what do you do next? So probably is switching to another SSRI. Because again, it's really hard to predict who's going to respond to which one. And then it starts to get a little bit more complicated. Then decide, do you want to augment? And the augmentation might be with a low-dose antipsychotic, not because you think the person has psychosis. It's just that we found that some of those medications that block dopamine also may be helpful on treatment-resistant OCD. And one thing that a point I wanted to underscore is I would never consider somebody medication-resistant unless they've also tried clomipramine or anafranil. It's not something to start with, but it's something that's worth trying in many cases.
And so once somebody, I want to point out really quick, because I think that's really important. We talk all the time about the critical need for people when you're doing OCD work, behavioral interventions, to be seeing an OCD specialist. And I want to talk for a second about that when it comes to psychiatry. I think sometimes people assume that all psychiatrists can treat OCD effectively and that they really understand it the way any psychiatrist would. Can you speak a little bit to the difference between psychiatrists who really have background and training in OCD and how they know how to appropriately kind of adjust and augment and think about it differently than someone who doesn't?
I agree, Liz, that if I were a consumer, I would try to go see a psychiatrist who has either seen a number of cases or has a supervisor or colleague that's kind of coaching them along the way, who has a lot of experience. I got a lot of my experience on my own, but I wouldn't recommend that for somebody starting out in the field. It would be good to work together with others who have more experience.
100%. And again, remember, for those of you watching that you think, well, how do I find that? If you're seeing an OCD specialist doing ERP, they often have psychiatrists that they work hand in hand with, that they know, kind of understand the behavioral intervention as well, understand OCD appropriately. And then of course, IOCDF has amazing resources. But when you think about major cities, a city like Houston, where Baylor College of Medicine has a specific clinic and we have leading experts in psychiatry, right? There's places that you can go to that you will have even a better chance of ending up with a specialist versus not. So let's kind of move on to next line. So medications have been tried, behavioral therapy. And I think it's really important that we talk about, because I know Dr. Goodman, you agree with this as well. Medication is not what we do alone, right? This is in conjunction with behavioral therapy. This is with ERP and CBT. But when do people start considering next stage or next level medical interventions, such as TMT?
Before we go there, Liz, the other thing I wanted to point out that is I've never told the patient that I with OCD that I can't think of something else to try. I've never sent somebody away and said, I can't think of anything else. There are a limited number of medication treatments that have been proven effective, but there are a number of other medications that are undergoing testing, or others that have been available for other disorders that are worth considering, as long as they're safe. I mean, that's where my starting point is. I want to make sure that whatever I'm prescribing is safe for that patient and they're being monitored. But there are lots of options, even though there aren't that many that are proven. So after you go through, so you've gone through an exhaustive list of medications, and either the patient's not having trouble tolerating the medications or they're not working, there are some other options to consider. And these are more the, what I'd refer to as neuromodulation. And one of them is non-invasive, and one of them is invasive. And let me explain what I mean by that. So non-invasive would be, an example would be transcranial magnetic stimulation, or TMS. And that's something where there are multiple sessions. You go to a place where there's a device that's placed on the outside of your scalp. The only thing you may feel is a little banging, but very little discomfort, generally very safe. You have to go for multiple sessions. And what it does is it has a fluctuating or changing magnetic field that induces currents inside your brain. And one device about a year or two ago was actually approved for the specifically for the treatment of OCD. And that device actually focuses on the center of the brain, because one of the regions that's been implicated in the cause of OCD is the cingulate cortex, and that's where it is in the midline. So there's a kind of a helmet that's placed over you. You go for multiple sessions over a number of weeks, and there's good evidence that's effective. Otherwise, the FDA would not have approved it. So that's the non-invasive.
Can we talk for a second? Can you
Sure.
differentiate traditional TMS compared to deep TMS and
Yes,
the differences?
I'm glad you mentioned that. So yeah, so some of the brain areas that have been implicated in the cause of OCD lie a little bit deeper in the brain. And most conventional TMS only reaches fairly superficial regions of the brain surface. So the deep TMS it's a specially designed coil that can reach deeper structures. And so that's the advantage for the treatment of OCD.
Got it. Perfect. And then maybe before we hop into DBS, we could talk for a little bit, if you don't mind, about ketamine, because a lot of people have questions about using ketamine and why or when.
Yeah, so ketamine for those has been found to be rapidly effective in the treatment of depression. Sometimes after a single dose, not right after the dose, interesting, but the day after, people with depression begin to feel that their symptoms are relieved. It takes multiple doses in order to get a sustained effect, and usually has to be in combination with another antidepressant. So there have been some studies, some publications from different groups on the use of ketamine for OCD, and the results have been mixed. Some have shown that it helps depression, which can be very helpful, because so many patients with OCD also suffer from depression. That may make a big difference. It may even allow them to be better engaged with ERP. But the results for OCD are not as clear as they are for the treatment of depression. That said, I think it's reasonable. It's available and approved as intranasal for depression. Some centers give it intravenously. And when a patient comes to me, and I tend to see, some of the most severe and treatment-resistant patients in the country and some internationally, I certainly, would say it's reasonable to try ketamine. And certainly before, try maybe more invasive treatments, it's worth trying. But we have to go into it realizing that the evidence base isn't that strong yet.
Definitely. So let's hop into your specialty, and something that I know I've learned a lot about from you directly, and I know the crowd is excited as well. So if you want to talk a little bit about what is DBS, what does DBS look like, and really like the way it's transformed over the years.
Yeah, so DBS, or deep brain stimulation, is surgery. And it's a surgery performed by a neurosurgeon, not by a psychiatrist. It's a approved treatment for severe movement disorders like Parkinson's disease. Worldwide is probably nearly 200,000 cases have been implanted. It involves a surgery in which leads are implanted in areas of the brain. Especially if my hair is beginning to recede, but if you don't have too much of a receding hairline, wouldn't even notice that you had it. The leads are tunneled under the skin, and it goes to what looks like a pacemaker, like a cardiac pacemaker, but in this case, it's a brain pacemaker that's under the skin. And my role in DBS for OCD is I actually go to the operating room with the patient, because we believe it or not, we wake up the patient. The brain itself has no pain fibers. They receive local anesthetic, and I test to see whether in the operating room we begin to see not a change in OCD. That doesn't happen right away, but sometimes we see an improvement in mood. Patients may report, as soon as I turn on the stimulation, that I feel happier, I feel less anxious, I feel like I have more energy. And that's a very helpful sign. And if we don't see it in the operating room, we hope to see it in some of the first programming sessions. So, so patients see me on an ongoing basis. And I try to do a little bit of therapy along the way, supportive therapy. But my main job at that point is to program the device. And I can make a lot of adjustments in the settings. And I've counted up recently. I think I've programmed in excess of 30 patients now over the years with OCD. It's not a cure. I want to be very clear about that. The rate of response is somewhere about 60%. I think recently we've been doing a little bit better. About 75% of our patients have shown significant improvement. And it takes a while to work. The initial what you see first is improvement in mood, and later improvement in OCD. And one of the other things that we've learned, and this has also been found by a group in Amsterdam that's done the most work with DBS in the world, is it enhances the effects of ERP. So we require all patients, before they go consent to having deep brain stimulation, to have had an adequate trial of ERP. But then we do, after we've seen some improvement of the DBS, we reinstate we do boosters of ERP, and that's when we see even better improvement.
That's, I think for a lot of people listening, there may be some anxiety around hearing surgery for OCD.
Yeah.
And it's something that, I think it's really important for us to make it clear that this wouldn't be first line, right? We don't start with DBS. It's really, but I think Dr. Goodman, you sharing 60% success rate, remembering for those of us listening, that is success from other treatments that have failed. Yeah. Right. So this isn't like, we know how successful ERP is. So we're talking about when traditional medications don't work, you still have a huge chance of success for DBS.
Yes. And it's not the last resort either. There used to be a time when we talked, there are other surgical approaches available. That includes producing, we call them ablative or lesion therapy, where you produce a small lesion in the brain to try to interrupt some of the pathways. My preference in general is to do the deep brain stimulation. I mean, there are cases where, ablation might make sense, lesion therapy might make sense. But in general, and the reasons I prefer it is, it's hard to know in the individual case exactly where to place the lesion. But with DBS, I can actually adjust the location of the electrical stimulation even after the surgery. And importantly, the hardware can be removed. So if it turns out, 12 or 18 months later, you've given it, you've got best try, but it hasn't worked, the hardware that was implanted could come out. And all the evidence suggests that the brain goes back to the state it was in, that we don't cause any permanent damage to the brain. And then there are companies that are undergoing trials of new medications for OCD. So even at the end of that, hopefully a person gets to the point where they're doing DBS, hopefully it responds, but if they don't, it's not the end of the road. It's not the last resort. There are other things that we can still try.
And I think that's a critical piece. I think oftentimes a lot of us think, oh, if ERP doesn't work, I'm treatment resistant. If first line medication doesn't work, I'm treatment resistant. And that's not the case. Those of us that do this for a living, right? We see all different levels of severity, all different types of diagnoses that may be combined. It's about really saying what's available for you and what should we try first, but what can we continue to add in and try? And kind of knowing that, hey, there's all these other options besides the first line standards, I think is really reassuring for a lot of patients. What do you think the future is, I guess, is a question I have for you. We know we've seen tremendous change and huge breakthroughs in the field so far, but what do you think is next if you had to guess?
So thank you. So we're currently conducting a research study with DBS that's funded by the National Institutes of Health, and the device that we're using not only can stimulate the brain, but allows us to record directly from the brain, and believe it or not, stream the information from the activity of the brain out to a receiver, basically using a Bluetooth-like system over about a span of about 3 meters. Our hope is to understand a great deal more about the circuitry of OCD. My goal is not to expand for there to be widespread use of neurosurgery for OCD. That's not the end goal. The end goal is to use this opportunity to understand more about the causes of OCD and the circuitry, and develop some non-invasive treatments that could be as effective as deep brain stimulation.
So one of the questions that we've gotten asked so far is, what do you do when, and this is for a provider, but what do you do when a lot of their clients already have a good relationship with psychiatrists who don't specialize in OCD? And how, as a provider, can we help speak with psychiatrists to encourage them to either become better versed in OCD medications or support the patient in an appropriate way? And just curious what your thoughts would be of how you'd respond to that.
Yeah, in general, there's certainly many patients I can think of who've had a very good relationship a therapeutic relationship with a psychiatrist. And hopefully most psychiatrists would recognize they may reach a point where, they need a consultation, a second opinion. And that doesn't mean necessarily I have to take over the treatment, but I can work as a consultant with that psychiatrist and often do. So I think it's very reasonable as a patient, to say, well, could I get a second opinion? And your treater, your physician should be open to that. If they're not, that's their problem.
Right. And I think that's the important piece, is it's just like, we see so many patients who come to us who have a great relationship with their outpatient therapist and clinician, but they're not an OCD specialist and they're not getting better. And so it doesn't mean you necessarily have to sever that relationship.
No, and they shouldn't take it personally.
Bingo, right? But this isn't personal. This is medical, and this is about progress. So let's go back to DBS for a second. So if someone were to get DBS, I guess one of my questions would be, what do you like how does it look? So they get the surgery. Let's say they're one of the 60% who really have success. What's next? How important is it for them to continue to engage in therapy after, and what does that look like?
Yeah, huge. I mean, so again, we as part of the study we're doing, we do 6 months of programming. I do the programming. It takes about 6 months, and then we introduce 2 months of ERP. And in all the cases that we've done so far with that have shown further improvement during ERP. And my thinking about this is that what DBS does is it changes a little bit a person's circuit bias, if you will. That most patients with OCD are very harm avoidant. It obviously varies a little bit in terms of the particular type of OCD, but they're very harm avoidant. With DBS, the balance changes a little bit, and patients find things a little bit more rewarding, and they seem to be less fearful of approaching the things that trigger their obsessions. It's not that it goes away immediately; it doesn't shut down OCD, but it competes with OCD very effectively. And then it takes time for people to learn and kind of experiment during the course of ERP and not avoiding doing what they learned to do in ERP, they begin to realize that the OCD doesn't have the same power over them anymore. And then they start extinguishing some of their old behaviors and that relate to OCD, and learning new ones that are much more rewarding and adaptive. And
so the takeaway, and you guys heard, I talked about this with Ethan last week, is that there isn't a cure, right? There's no, I think all of us with OCD would love a quick fix. We'd love to know, I'm going to go to this doctor and they're going to fix it. But whether you're doing medication and ERP, whether it's DBS and then ERP, it doesn't matter, right? It's about management and learning to still use all the tools, right? All the skills. So if we have that kind of base belief that I'm going to go here and this medication is just going to fix me and make it better, I feel like that's oftentimes when a lot of us become disappointed because we're let down by the process. So just knowing that it is a combined process, right? The treatment intervention is integrated. It's not siloed.
Yeah, and there's always going to be a little bit of a battle. And OCD is for those of you who have it and those of us who treat it, know it's a very active, dynamic process. And it's almost like it's something inside your brain that's trying to take over and make your life miserable. And it's going to look for opportunities to do that. So you have to be vigilant. You have to expect that there are going to be days when it's going to come back, and you got to be prepared for it and use all the tools available.
Exactly right. Exactly right. So a couple other questions. We talked a little bit about kind of the basics and when somebody would be suitable. Can you talk for a second? I don't want us to go into detail about medical treatments for children and teens, but my understanding is that medication pharmacology is something that's considered for children and teens, but that TMS and DBS would not be.
So there's no question that that for children and adolescents, first line treatment is ERP. Yes. So the times that we would consider medications are those that may either have had trouble adhering to the ERP, and that may be because already their anxiety levels are so high, or that they have depression. And if it's depression, it's going to be very hard to have the motivation to be able to adhere to ERP treatment. So there are only a few medications that have been approved in children. One of them is fluoxetine. Clomipramine is another one. There certainly is a role for it. The dosing is different. And I would make sure that a child and adolescent psychiatrist is doing the prescribing.
Yeah, absolutely. And so when we think about kind of medication and how it works, we talked a little bit about advocating for it. We've talked a little bit about how people can go about it. Some of the questions I'm seeing are like, what do you do if there's not a specialist? This is where, as an advocate for OCD, it's important to remember the biggest advocates are ourselves, and we have to keep advocating and keep looking and searching. If you're at the VA, asking if there's somebody there who does ERP work. There's actually been a lot of OCD work within the VA. And if there isn't, the VA may be willing to cover outside treatment. And so how can you think about, I know someone asked that specifically, some of the resources that are there? One of the questions from a guest is there a specific number of medication failures required in order to qualify for DBS? And what about the specific duration of therapy before being approved? Or
that's a good question. Yeah, we have very specific what we call inclusion and exclusion criteria. So we would require that the patients had tried and failed an adequate trial of multiple SSRIs alone, SSRIs plus a low-dose antipsychotic, and examples would be risperidol or aripiprazole, and that they also failed clomipramine. I want to bring up that point again. It's often trying clomipramine is often forgotten because it's one of the older generation of medications that has more of a side effect burden. It's got some safety issues. But again, I wouldn't even consider DBS unless it was tried. Now, there are some patients that have tried the medications, they've tried to have an adequate trial, but they couldn't tolerate it. So that, that would be some of those patients we might include if we felt that really they had proven to be intolerant of medications. In addition, importantly, they had to have had an adequate trial of ERP. We look at that very carefully. We really want to make sure it was done therapist assisted, expert hands, and it was adequate in scope and duration.
And I think that's one of the reasons, it's so important. You guys hear us talking about ERP all the time versus just CBT or, general therapy, is that a lot of people think, well, I've tried treatment or I've tried therapy for OCD and it doesn't work, but they haven't had specialized ERP treatment. They haven't had treatment by an OCD clinician. They haven't had medication prescribed by a psychiatrist who understands OCD. And there is very clear differences. One of the things you guys have heard Dr. Goodman talk about for the past, since, we started this talk at noon Eastern, is that there are specific medications that work for OCD. And there's kind of a specific route that really psychiatrists should be taking. Behavioral interventions, it's the same way, right? CBT alone doesn't help OCD. Talk therapy doesn't help OCD, but it's a specific form of CBT called ERP that needs to be tried. And so it's really important that we don't understand all mental health therapy, all psychiatric medications in like one, that we don't lump them together and say, oh, well, I tried this and I didn't work. Did we try the right thing? And did we try what we know has the most science and evidence behind it as being effective? Last question that was asked is, can you talk a little bit more about deep TMS? And is there a possibility that it could move its way into a first-line treatment with ERP and SSRIs?
There haven't been. The other thing I wanted to mention about TMS, and I failed to do, is that we are interested in seeing it examined, and I think that the company that makes the TMS may be interested in looking at it in adolescents. So hopefully, we'll be over the next year or two, we'll be able to generate some data to look at whether it's effective in that younger age group. At this point, I couldn't say exactly where we would place TMS and kind of the algorithm for, we're talking about medically based treatments. I think one of the issues right now is access and funding of reimbursement of TMS. Even though it's approved by the FDA, in experience of many patients, their insurance companies are not covering it, so it can be costly. It also involves a very large time investment on the part of the patient. So I don't think, certainly at this point, I wouldn't see it as first line, except in those patients that, and people are entitled to these feelings. They may not like the idea of any medication, not just SRIs, but having any medication in their system, and prefer the idea of something non-invasive like TMS, and I fully respect that. Or in patients that have tried many medications and have had a boatload of side effects. So a TMS would certainly be an option, but I'm not exact. So, and the question comes up around deep brain stimulation too. Should we require that patients have TMS first? And it's an area of discussion. If patients come to me and we're doing an evaluation for DBS and they ask about TMS and they can afford the treatment, they have the time to commit to it, I'd say absolutely go ahead and try it. We'd all feel better if you tried a non-invasive approach first. But it's not clear how effective it is in the patients that have very severe treatment-resistant OCD.
Absolutely. A couple other questions that have come in. This one, what if a person's OCD came from some damage from fetal alcohol exposure? Would DBS be out as a potential treatment?
That falls in the category of kind of the caveats you said the early part. We really know a lot more individual details.
Right. Right. So,
but in terms of exclusions for DBS, if there was evidence of specific brain damage, particularly in areas where where the neurosurgeon would be operating, it might not be effective. Right. So I would have to know the details of the particular case.
And so this is where we would recommend that you reach out specifically to individuals or centers who do DBS for OCD to get an individual consult. One of the last questions is if DBS, is DBS FDA approved for OCD? And if so, what do you often see with insurance coverage?
For DBS? I'm sorry?
Yes.
Yeah, it's a similar problem. It's very variable, and it usually requires a fight. with the insurance provider, usually carrier, and that fight is carried on by the patient's family, by the physician. I've certainly, and what I look for is I really usually raise issues of parity. So if I identify that an insurance company is paying for a DBS for dystonia, which is a movement disorder, and they're not going to do it for OCD, I raise the issue of a disparity with treatment for what's considered a mental disorder. So it's variable, and it often is a fight. With the research studies that we're currently doing, it's at no cost to the patients. It's because it's funded by the NIH.
And we will be sure to share links and information to BCM at the end of this talk, so that those of you who would like to get in touch because you want to be considered for this research study, you can definitely reach out, and we would encourage you to do so. There is a specific question for a 15-year-old medication-wise, and so what I'll say is that we're not going to answer specific medication questions, especially for teens. What I would recommend, Kirsty, is to find an OCD specialist and a psychiatrist who specializes in children and adolescents, so that they can really go through specific dosage for you. Last question for today is, when you say treatment resistant, do you mean poor response to medication or poor response to ERP?
You're right. I should be more specific. So generally, when I'm talking about somebody who would be considered for DBS, we're talking about somebody who has severe OCD, a Y box of usually around 30 or more, which puts them in the severe to extreme range. They've had to have OCD for at least 5 years, and they had to be resistant to and not responded to, not had significant benefit from adequate trials of the medications we talked about, as well as ERP. But there are some cases where they're just intolerant of the medications. And sometimes, I'll review the history very carefully, and it may be that just they were prescribed a medication at too high a dose, and they need to start at a lower dose and work their way up. So in those cases, we might recommend, trying again. I often want to see in my own hands that they really couldn't tolerate the medication before we would turn to a neurosurgical approach.
Yeah, and again, remember, treatment resistance is a term that I think is thrown around often. And again, remembering when we're talking about ERP or medication, it's about the gold standard treatment approach, right? So it's not, I've tried general therapy or I've tried general medications, but have you tried OCD specific medications? Have you tried OCD specific therapy? And what did the outcomes look like? So this has been absolutely incredible, Dr. Goodman. I know so many have learned so much today. And I think, again, really what we talked about today is making sure at the end of the day that you are getting specialized care, that you are not thinking medication or certain interventions come above ERP, but instead that they go hand in hand, right? We know the gold standard is often a combination of both ERP and medication, and that, again, there tends to be a systematic approach, starting with specific SSRIs for OCD and then building your way up and trying other things if those don't work. The most important piece I want to leave everybody with today that Dr. Goodman talks about all the time, that I echo to all of my patients, is that help and hope are always available. We should never think that this is my last resort. If I don't try this, then there's not help for me. There's never a last resort. There's always ways treatment and interventions can be augmented and new things can come about. Look at deep TMS, for example, right? That's something that is really new when you think about interventions that we're trying for OCD. And so it's really important and critical that if the first line approaches didn't work for you, get with a specialist, somebody like Dr. Goodman, who has spent their career thinking about other approaches and ways that they can always find additional options and avenues to help patients with OCD.
Can I say one last thing, Liz?
Absolutely. Please do so.
Dr. Liz McIngvale is probably the world's foremost advocate for OCD and the most amazing clinician. And I want to thank you for having me. And
Well, thank you.
For what you do for patients.
Well, I appreciate that. It's my pleasure, but it's because of people like you and Dr. Janicki who really helped lead the field for us to even know that treatment was available and that treatment exists. So thank you for all that you do. Thank you for your comments. And thank you to everybody for joining today. Until next time, remember, help and hope are always available.